Hello, everyone. My name is Dr. Michael Mamone. I'll be presenting a case of Nocardia farcinica, which is an emerging pathogen in the immunocompromised. I'm associated with Florida Atlantic University. I'm an internal medicine resident. My co-authors are Teresa Cogger, Andrew Wang, and Lila Tao. Some background information on the case. So Nocardia farcinica is a gram-positive branching bacillus. It is a weakly acid-fast staining bacilli and can cause a variety of clinical presentations, including cerebral abscess, keratitis, bacteremia, pulmonary, kidney, and cutaneous infections. However, when you have nocardia CNS infection, this typically occurs in those immunocompromised individuals and presents with the highest mortality rates of other manifestations. So our case presentation, this is a 72-year-old male. He has a history of diffuse large B-cell lymphoma status post R-EPOCH. He's currently in remission, as well as acute myeloid leukemia status post FLAG. He presented to the hospital due to worsening memory issues and confusion for the last several days. Really only pertinent physical exam findings was that he was AO times 2, however had no appreciable focal neurological deficits. On laboratory examination, he had a little leukocytosis of 12.6 with some macrocytosis. However, his MRI imaging did reveal a single 2.5 centimeter peripheral enhancing lesion in the right frontal lobe with some surrounding vasogenic edema with mass effect. And this can be seen in figure 1 on the bottom left. So he underwent a stereotatic biopsy with frank pus, which was expelled from the mass. These collected specimens were sent for cultures, and they came back as weakly positive for acid-fast bacilli, and then the cultures grew Nocardia farcinica. So the patient was initially managed with dual therapy with IV Bactrim with imipenem. However, he was developing worsening thrombocytopenia, and this was eventually transitioned to ciprofloxacin and imipenem therapy based off the current sensitivities that we had. So Nocardia species have a particular tropism for the CNS, and especially in those with disseminated disease. In our patient, his disease is only localized to the CNS. But however, when dissemination occurs, the disease tends to present as headaches, seizures, mental status changes, confusion, ataxia, or focal neurological deficits, depending on where, if there is an abscess, is located. So a brain abscess is usually seen via advanced imaging with CT or MRI, with MRI being the image modality of choice. And when it comes to treatment for these patients, the drug of choice is actually IV Bactrim. It should be IV TMP-SMX, 15 mg per kg per day, with imipenem therapy, especially in those immunocompromised patients. But depending on the size of the abscess and severity of neurological symptoms, it most likely will need to go under surgical intervention with an incision and drainage. And duration of therapy in these patients is 6 weeks in those immunocompromised individual, and this will be followed by oral therapy of 12 months, typically monotherapy with Bactrim. And those that have the CNS involvement have an all-cause 1-year mortality of roughly 19%. So in conclusion, CNS nocardiosis is typically seen in the immunocompromised patient population. Mortality rates are high if left untreated, and medical with concurrent surgical management is indicated if abscess is present. And the patient should complete 6 weeks of IV antibiotics, followed by 12 months of oral therapy, and TMP-SMX is the drug of choice. And of course, afterwards, you'll need to do a follow-up CT or MRI imaging to document complete resolution of abscess. My references are located in the bottom right corner. I appreciate for listening to my lecture. Thank you.